Thanks, Harry, and thanks for all the hospitality you've all offered me here today. You know, this is the 40th anniversary of Monty Python, so it probably is appropriate for me to say, and now for something completely different, because this is very different from what you've heard this morning. We study rare diseases, and this talk today isn't exactly about rare diseases, because rare diseases, by federal law of 1983, the Orphan Drug Bill, means a disorder that affects fewer than 200,000 individuals in the United States. And the diseases that I study have frequencies of the order of about 1 in 100,000 or so, some even less than that. By the way, Hermansi-Pudlak syndrome is here in New York City because of the Puerto Rican population. There's a HPS type 1, which is albinism and a bleeding disorder due to a lack of dense granules in the platelets. A very interesting disorder, anyway. It has to do with cell organelles. But that's just an aside. Point is, these are rare disorders, but what I'm going to talk about today are disorders that are so rare they haven't been discovered yet. And that really is one of the many purposes of the Undiagnosed Disease program that I'm going to talk about today. And I have to start out by telling you some reasonably boring things about how this originated. But then to go on to some interesting stuff to show you some patients here, which we find quite fascinating. As Jesse Roth mentioned with me last night, this is really how a lot of the physicians at the NIH basically got their jobs by studying these rare disorders. So, of course, there are like 23,000 genes, and there are 6,000 diseases. So that means there should be a lot of diseases that we still haven't discovered yet. And there are a lot of experts in these rare diseases. And we know how to take care of them. And it's a great amount of solace for a patient to go in and to say, now I have a diagnosis, this is what it is. The doctor can look it up, or the doctor can plead ignorance for a while and get consults and things of that sort. But if you don't have a diagnosis, you're screwed in a lot of ways. So that's one of the issues. So it also is true that the Office of Rare Disease, which is now called the Office of Rare Disease Research, they changed their name, is supposed to get calls from patients who want help with their rare diseases. But a good percentage of the calls that they get are from patients who don't even have a diagnosis yet. Furthermore, the patients who do have rare disease diagnosed often took years to get that diagnosis. So can we help out with reaching a diagnosis here? And in addition, the Institute and Center directors at the NIH wanted to revitalize the clinical center to a certain extent, and one of these their short-term goals was to recreate what they called the fascinoma clinics of the 60s and 70s. So we'd like to help patients reach a diagnosis, and we'd also like to discover new diseases. It turns out that a third goal of this program was also, let's say, occurred or evolved after the first few months, and that goal is to make the NIH famous. In other words, to put this in the communications arena and give good public relations to the NIH. So the way this works is that applicants will submit their medical records, and they'll do so through their physician, who has to write a summary letter. Then I triage all the submitted records and give them to different experts who can look them over and say, is this suitable or is this not suitable? And then they come back and I synthesize that and decide yay or nay on this. So in a way, it's a little bit like a mom and pop shop here. And then we tell the patients, and the ones who are accepted come in for a week, sometimes week and a half or 2 weeks or so. So this was announced on May 19th, 2008, and Dr. Zerhouni was there. And this was broadcast, and they made a big deal out of it. Dr. Zerhouni, just before this was announced at 11 o'clock on that day, about 5 minutes to, turned to me and said, why now? Why are you doing this at this juncture? And I said, because the Office of Rare Disease gave us $280,000. And this was actually the factual reason why this occurred, because that provided us with the salaries for 2 nurse practitioners, etc. And Dr. Zerhouni, understanding the entire economics of all this, sort of discounted that. He just completely ignored what I said and said, No, but really, why not? And the point is that you can't start a program like this with $280,000. It was ludicrous, but you have to start somewhere, is the way we felt. And then when it was publicized, there was all sorts of money poured into it because they didn't want to be embarrassed by stopping it. But Elias, being the smart guy that he is, just completely disregarded whatever I said, and then publicly announced that now that we have the human genome, it's appropriate for us to start it at this time and try to link some of the genetics with the clinical. So that's why he's in his job and why I'm still sitting here as a clinical director. Anyway, got a lot of press and stuff like that. So you don't need to know about that. And it was in Newsweek magazine, etc. Okay. So, but then, by the time it got to the fall, so a few months later, we were just completely overwhelmed with records. And I liken it to this. The difference was, there's no candy to eat, but, like I say, we're screwed. Okay. So the numbers are now, after now, 18 months-ish or so, 16, 18 months, whatever. We have had 2,400 inquiries, and about 1,000 people have sent their medical records to us. And some of these medical records, one of them was in a 10-ream box, but probably about 20 to 30 of them are this high. The average one is about an inch to inch and a half higher, so maybe 200 pages-ish. We're able to reject a lot of them, and we've accepted about 210. Now, originally, these patients, some of them, or many of them, were accepted to other services at the NIH. But the other services rapidly found out what a drain this is, and really is against the paradigm of advancement for young investigators, to study unknown diagnoses where there's a low chance that you'll find anything. So basically, a lot of the other investigators at the NIH demurred, and patients are now pretty much admitted on my service, but we have access to all the consults, so they get involved anyway. Don't seem to mind it at all as it occurs, because they end up with very interesting cases. To show you the seriousness of this, 13 of the patients who have applied to this have died already. And more than half the cases are neurological, and then we get a lot of genetic disorders of children. This is our personnel, and so the unpaid consultants are really, these are the NIH principal investigators who are experts in this or that or that or that. And these are some of the things they're experts in. But really it goes even more broadly than this. And honestly, it's quite, let's say, inspiring the way that our colleagues have been willing to review medical records and been willing to consult on these undiagnosed patients who are real mysteries and who, by and large, do not contribute to the specific area of interest of the physicians. It's something that can be done at the NIH. I think that it can be done at universities too, but it needs a certain amount of stimulus. Okay, so we have these planning meetings, and see my bald head is rearing itself. We triage these records, and often we'll ask for more information, like the actual slides. And the pathology departments send our pathology departments those slides, and then our consultants can look over the slides. And the same thing goes for the images in radiology. And sometimes we need more information. Then there are pediatrics meetings, which are separate, because it's a different group of people sitting around the table. And then we have open meetings once a month in which we present 6 to 10 cases with pathology and radiology. And this is largely for sort of advertising and showing off in a way. We don't do too much decision making at this because there's 60 people in the room. Pretty much the decisions about accept or reject are made behind closed doors by our consultants or me. And then we're able to do million SNP arrays for genetic analysis because these patients are so nicely phenotyped and so nicely worked up, because it doesn't cost anything at the NIH for them. And so Tom Markello does this, and you can tell the platforms here and some of the software that's used. In general, million SNP arrays detect copy number variants and runs of homozygosity. And this can be helpful in pointing us to areas that we might pursue as the genetic cause of some of these patients. So single nucleotide polymorphisms are oligonucleotide sequences in which there's a variant. So now if you have a million of these, it means that there's on average one every 3,000 bases, because we have 3.2 billion bases in our genome. And so you can, so the difference is here, and the difference is here. And this will tell you if you're this or this at that site, and these 3,000 are picked out so that we all have a reasonable, as a population, percentage of these. So it would be 70, 30, 60, 40, something of that sort, so they're common enough. And by definition, the B allele frequency is always the least common of the two. So you can determine the A and B allele frequency and do it by intensities here. So BB would be here, AA would be here, and if you're a heterozygote, you're here. And if you're, let's say, deleted and only have a B or only have an A, that's the way you look. That's the intensity that you'll have in the read. And this is all printed out for all these million SNPs. This is the name of the SNP. And here, for example, is an AB allele, in this case, intensity of 0.5. Sometimes this takes a little second to show up here. And that is the R ratio of intensities of the B allele and the A allele. And so if you're heterozygote, your log R ratio is going to be 0, which you see right here. And here's an example of intensity here. This is the centromere, which has no SNPs in it, so it's always going to be blank there. But if you look here, these are low intensities. And this can be aligned to the human genome, which is annotated here, so you can determine what gene there's low intensity in. Low intensity means a deletion. And this is an example where all these SNPs are deleted consecutively. And it turns out it's in chromosome 17, which and the 32 SNPs encompassing this region. Turns out that this is the region that the disease that I study for the last 28 years, which is cystinosis. And in cystinosis, there's a very common 57,257 base pair deletion that arose in Germany in about 700 AD or so, that is involved in half of the European and American patients who have cystinosis. So this just gives you an idea of what you can see with a SNP array. Then this is the other way of presenting it. These are SNPs that are homozygous for BB, for AA, and these are the heterozygotes. And this again is a centromere. But the heterozygotes here are some things that you can isolate. In other words, you can forget about these and just determine the heterozygosity. And so these are those lined up by Dr. Markello for different patients in a single chromosome. So these are all different patients in a chromosome. And here, for example, is an area where there's no heterozygosity. Okay? And there's another area. And here's one of our UDP patients who had inflammatory leukoencephalopathy. And if you look at him, he turns out has all these different areas. So it turns out that he has consanguinity in his family, and that's why there's homozygosity in these many regions. The homozygosity accounts to enough so that the total consanguinity makes him the product of roughly a second cousin marriage. So remember, first cousins share 1/8 of their genes, second cousins share 1/32 of their genes, 3% homozygosity. That's what this all will add up to. Okay, I think this is going to... Okay. So let me tell you something now in a more interesting vein about some of the patients that we've seen whom we know very little about except their phenotype and that they're interesting. Here's a woman who has burning facial pain and erythema. You can see the erythema. And this is only on her face. It's not on other parts of her body. And so she has to have the room temperature 58 degrees and puts a fan on it, and her face hurts. And there's some sort of autonomic dysfunction, but it's segmental. So anybody see this in this room? Anybody have an idea? You know, these are things that our physicians haven't seen. Maybe there's a report in the literature occasionally, but this woman her life is devastated by this. You can sort of imagine. It's very painful. Here's a 56-year-old woman who has this rash, and she was actually fine until a few years ago. And then she took, well, let me describe these are keratotic lesions, like spines sticking out, that essentially developed all over her body after she had taken PUVA and retinoic acid. So this is UV light and then a retinoic acid. And these things are extremely sharp. She can't sit down or put her arm anywhere. And this is her scalp. And so anyway, she's a mess. And this is a close-up of this. And this is the pathology. And so you can sort of see the keratin coming out of here. And sort of right at the base here, the cells producing the keratin are more, let's say, robust than they should be. There's a dermatologist in the crowd. You can either correct me or you can agree or whatever. But look at all this layering here. So anybody see anything like this before? Because our dermatologist hadn't, and they consulted people in the whole metropolitan region. So, you know, what might she have? Well, it turns out, and we don't actually know, but we may have a clue here. In the 1Q, there's a homozygous deletion of 2 consecutive SNPs that code for the promoter region of LC1E, which is a member of the late cornified envelope 1E genes. So that may be a clue for us to pursue. Here's a 10-year-old boy who's perfectly fine. This is every parent's nightmare. He developed the limp at age 6, then became hemiplegic, and now he's steroid dependent because if you take him off steroids, his trachea closes. So, and he has basal ganglia and paraventricular white matter disease, you see here. Now, he has 53 genes in a region here that is 16 megabases on chromosome 3 that has absence of absence of heterozygosity, meaning homozygous. So these would be candidate genes really surrounding the centromere here. Then here are a couple of siblings from the Chicago area who have this short stature and some bowel and bladder problems and are developmentally delayed. They have macrocephaly. And we don't know what they have, but our folks have not seen anything like that. Here's a 4-year-old girl who has some sort of an ectodermal dysplasia, but not one of the known types of ectodermal dysplasia. And you can read about this, but the main issue here is that she has bony overgrowth of her skull, which is impeding the optic nerve tract here. And that's why she has some papilledema. And we're quite concerned about her future vision over this. And again, we don't know what she's got. Her sister is in psychiatric care because she doesn't understand why this girl is made fun of by her classmates. And here's a 3-year-old girl whose parents are incredibly devoted to her and really doesn't respond to their parents at all. This is an interesting case of a young lady who has many different things affected by her. But the developmental delay is only one of the issues. The thing that really can be intriguing and be used as sort of a tool for us, a hook, something to go after, is her liver disease. And her liver disease is shown here as the beginning of bridging fibrosis, as inflammation with the lymphocytes here, and then as something that hepatologists have not seen before in a known disease, and that is copper accumulation in zone 3. Ordinarily, a copper accumulation in any childhood cirrhosis or Wilson disease would be in zone 1, which is more near the vasculature. But in this case, it's in zone 3. And there seems to be a canalicular problem because in this biocanalicula's, which you can see is defined by the cuboidal cells surrounding it, there's an actual space. And I'm told by the hepatologist that that space is supposed to be a virtual space, not be seen on these on histology. So that means that the cells surrounding it are dilated, and that's abnormal. So this gives us sort of a clue as to go after it, sort of the multisystemic disorder that this young lady has. Then this is a 2-year-old boy who has corneal scarring. He's pretty miserable most of the time. And conjunctivitis, hearing loss, and delays. Again, we don't know what he's got. And other children who have different things. You can see what the lady says on her T-shirt. And so it's more than 10 doctors now. So those are things that where we don't really know what we're doing. Which incidentally is something that we pretty much tell our patients. That is, we really don't know what's going on here. We try to give them low expectations. It's like a dating service. Lowered expectations. So we start out and tell them that, and of course we can't really control expectations completely, but we do try. So here's a 21-year-old woman from the Louisiana region who has the lung nodules. I mean, you can see those. And she has hydronephrosis because her ureter was kinked. You know, this kidney compared to this kidney. And she has ascites. And it's sort of on and off. And again, we really don't know why. But she also has masses in her cheek that grow. And they're fibrotic, but also inflammatory. And she's also had a lung biopsy, which shows the same process. So the same process is going on in those nodules as in her jaw. And she actually, at the NIH, had 4 hours of surgery to get biopsies from her jaw because it's almost acting like a malignancy, but it isn't malignant on histology. It's caught between the fibrotic, I should say, between the inflammatory phase and the fibrotic phase. And we really don't know why. See, she does have these sort of CD34 positive primitive cells. And so it's called angiolymphoid hyperplasia with eosinophilia, because there's some eos in there as well, and a fibroinflammatory disease. She has circulating cytokines that are increased, so this provides us with a clue. And we think that we can look at the cytokine and the receptor array on the on the cells of the tissue that we've obtained from biopsy and also cultured cells. And so we're going to bring her back and even a third time and see if there can be some sort of even possibly anti-cytokine therapy for her, because the growth within her pterygomaxillary sinus and essentially around her jaw is such that she can only open her mouth 8 millimeters, and so it's hard for her to eat, and it's getting worse. Only 21 years old. She was in the ICU when there was a hurricane, and the hospital lost its lighting and its electricity, so they had to evacuate, and the attending physician, rushing her out, gave her her ambu bag to have her breathe for herself. So she's a strong young woman, and we like her. So here's a 46-year-old woman who has thrombotic microangiopathy, and you can read that. Okay. Now she's got elevated VEGF, and that's why I put her in this pool of individuals whom we can sort of pursue with some vigor. Her kidney shows certainly some thickening of her arterial walls, or her vessel walls, anyway. And but she has this proliferation and some red cells here, and abnormalities which are called thrombotic microangiopathy, which is seen in certain disorders as well as in preeclampsia. And in fact, the cause of preeclampsia is now recognized as production by the placenta of antibodies to VEGF, vascular endothelial growth factor. So that obviously, the treatment for preeclampsia is to deliver, get rid of the source of those antibodies, and then the patient's generally okay if you do it in time. Well, this woman has this increased VEGF, and there's blunting then of the podocytes. This is not completely normal looking. They're supposed to be all nice and regular stuff at the mesangial wall here. So we think that we can pursue whether or not she has an abnormality in VEGF itself or has an abnormal VEGF antibody that's circulating and preventing the trophic influences of VEGF on the kidney. It's also causing her to have these pyogenic granulomas. I bring that woman up because it's similar to this woman in many respects. This is a woman who is featured in the New York Times Magazine article about this program. And she had an enucleated eye when she was about 10 years old because she had what they called Colt's disease, but really she had vascular, the vessels of her retina were leaking. And they couldn't cauterize them enough. And so they eventually had to take out her eye, although I think the circumstances surrounding that are a little bit uncertain, because I don't know why you'd take out an eye exactly for that. In any event, this is what she looked like. She had these abnormal nails, and she had the same vascular process of thrombotic microangiopathy with splitting of the membranes here on this silver stain. She also had some brawniness to her legs. And so that's she. And the point is that both of these individuals may have problems with VEGF, for which there is no known disease outside of preeclampsia that I know of anyway. So we can pursue that as one of the possible causes. Then here's a 39-year-old man who had spastic paraparesis, dysarthria, bowel and bladder dysfunction, sensory abnormalities, and came to us with a possible diagnosis of a leukoencephalopathy. And he had progression of his disease. And you can see here and here, these are abnormalities in the MRI of the brain. And his disease had progressed to this enormous extent, where he has all this atrophy. He was a dean of a community college in the Midwest and was fired, essentially. So he comes to the NIH, and our folks eliminated the diagnosis of leukoencephalopathy as the primary cause and made the diagnosis of primary progressive multiple sclerosis based upon the oligoclonal bands in his CSF on our spinal tap, and also the increased protein in IgG. But the neurologist who works with us also found increased EBV antibody titers with a positive PCR. So this is a patient who has ongoing infection with EBV, and EBV is hypothesized to be a possible cause of primary progressive multiple sclerosis. And this may be an index case that gives some greater credibility to that. And so we're working on that as possible. Now, I just want to mention two success stories. So remember the numbers here: 1,000 charts to go to. Let's say accept 200 patients or so, see about 100 so far. And of those 100, we have a few good cases to work on, and we found two things. Okay, so this is a distillate. It goes to show how difficult the problems are and what type of investment one needs to make in these individuals by virtue of having thrown out hundreds of cases that none of you wants to see. You don't even want to hear about it. Some of them are really just, an 85-year-old woman with bruises on her thigh in a nursing home. Who would? Never mind. But still, good cases in the distillate. So here's a 52-year-old woman who noticed over the course of the last 4 or 5 years increased muscle but no increased strength, and it's beginning to strain her. It doesn't feel good, and it's hurtful now. Again, no drugs. It's not acromegalic. I mean, this is muscle. It's not bone. And she has a myopathic EMG, but normal muscle biopsy. And you can see the amount of muscle she's got. This is some men might want this. no woman, well, actually, there's some women who actually do want this. But they lift weights, and they have steroids, et cetera, et cetera. This is a woman who really didn't want all this. You can see her muscles of her abdomen. And when our neuroradiologist saw the MRI of her head, they were astounded because the muscles, the lateral rectus muscles of her eye are 3 to 4 times the normal size. So it's just not working those out. So this is actually a very remarkable finding. The endocrinologist from Duke who referred this says, in all my 38 years, I've never blah, blah, blah. But this is a woman, too, who tried to get into specialty clinics at other places. On 2 occasions, she wrote to Mayo asking, would they see her? And they would not see her. And why? Because the specialists were so specialists that they couldn't figure out, where does she fit? So where would you send a person like this? So nobody took her. She had a systemic disease. So at the NIH, even though she'd had muscle biopsy a year before that was normal, we did another muscle biopsy, sent it to AFIP, and they found these thickness within the vessel walls of the muscle, and they found Congo red staining indicating amyloid, and they found amyloid on EM as well. And when you think amyloid, you think of, at least there's one cause of multiple myeloma. So we did a bone marrow and found 10% plasma cells, and she in fact had light chain disease. And she was near a critical stage in her life, which is to say she had involvement of her atria of her heart, but not her ventricles yet. And apparently once you get involvement of your ventricles, you're pretty much out of luck. There's nothing much you can do. So where did we refer her? To the Mayo Clinic. Because now she had a diagnosis, and the world's experts are at the Mayo Clinic. They were happy to receive her, did a stem cell transplant. She's doing very nicely now. And she's among the most appreciative people in the world for having been found out. Okay, then the other sort of success story is this. We saw these 2 individuals, again from really, I guess, near Cincinnati, who siblings. And they actually have 3 other siblings who have exactly the same thing, which is calcification of their fairly large vessels, essentially below the waist, and nothing in their coronaries at all. So this is reasonably unusual, right? So this is a plain film, right? Just so you know, of the vessels. They have claudication. It's painful for them to walk. Of the 5 of them that are affected, and incidentally, there's no other family history, no parents, no children, so this is going to be autosomal recessive. Of the 5 of them, they can walk between 1 and 6 blocks without stopping in significant pain. Actually, CNN came, and I selected these individuals for Sanjay Gupta, and Sanjay is... if you ever see it, he's there pointing to the x-rays of this, saying, now, that's a bone, and that's a vessel, and that's not supposed to be there. So,
He's a neurosurgeon.
Yeah, he's a neurosurgeon. That's right. So, but he knows this. He's a very nice guy, by the way. Anyway, so then you see it here as well. And these individuals, here down there, okay, they also have joint capsule calcification here. So that's not supposed to be. That's like a sesamoid bone, I guess. But that's not supposed to be. And that's not supposed to be. Okay. So this is the pedigree. Parents, third cousins. Extremely nice family. And but we did elicit the help of someone in LBI, the Heart, Lung, and Blood Institute, and Dr. Boehm's lab actually studies vascular endothelial cells. So he cultured them, and he cultured fibroblasts, and performed this calcification assay, which after 17 days here or so, you can see in the control, there's no acquisition of calcium, but this calcium stain, that's a calcium stain. So after roughly 2 to 3 weeks, you see that in these individual cells. So that placed the defect in the cells as opposed to anything circulating like abnormal calcium or phosphate or vitamin D or something of that sort. So that was very helpful. So now we know it's a cell problem. And then the million SNP array showed that in the entire genome of these individuals, these being the parents and these 5 being the affected, there was only one region of homozygosity shared by all of these and not by any of these. And you can see this again is the heterozygote region here, the heterozygote SNPs. So these folks, the parents have heterozygosity here, the children do not, and these are the affected. So we look for a gene in there, and in fact, there were 22 megabases with 92 genes, but it turns out that the people in Dr. Boehm's lab actually knew to pick one of the genes and picked the gene and found the gene, and now we're basically writing that up. So let me tell you about the good parts of this program. The patients are essentially universally pleased. The only ones who aren't pleased are the ones who have psychiatric illness. But they're all happy to have us spend a week or a week and a half seeing them and giving them what information we have and promising them that we're going to work on things in the future. And I must say that I'm astounded at how pleased people are with our failures as physicians. You know, as if we admit these things. And the level of frustration of patients who come to their physicians is enormous when they don't have a diagnosis, because the physicians themselves are embarrassed. We're embarrassed not to offer anything. And sometimes the patients are offered ridiculous things, including ridiculous diagnoses, but also therapies. And so they're happy just to have sort of a measure of honest admission of our ignorance over this. And we're in a position where we can do it. I mean, not every physician can do that because, you know, they have credibility issues. But at the NIH, it's not hard for me to go in and say, I don't know what I'm doing. So we do it a lot. That's good. Some new cases. This has been very, let's say, helpful for our community at the NIH to bring people together over the cases. And helps our protocols somewhat. Right. And not so good. When we triage and turn people down, it disappoints a lot of folks. So that really is an issue. Yeah. Some applicants, yes. So we've had like 8 congressional inquiries. Most of the congressional inquiries, the patients have not applied to the program yet. They went right to their congressperson. So that's pretty irritating. And we don't meet our goals in terms of time response sometimes. For every great case we see, we have to review a huge number of records. And many patients have subjective complaints without objective findings, and we still have to go through the record just to make sure they don't have the objective findings. So, future, we want to have a research arm of this, which is much stronger, and we're developing that now. We want to determine, by using these individual cases as substrate, how good whole exome sequencing is, for example, or whether whole genome sequencing would be reasonable. And we're in a place that can do that, and we have the funding for it, so that'll be okay. We'd like to post these cases for the NIH and the international community so that they can do it in a de-identified fashion, so that they can count on them, and perhaps create clinics like this that are supported by the NIH at other medical centers throughout the country, maybe 6 or 8 of those supported by CTSA. Insights. So we have to admit patients to my service and then consult specialty services. And again, many of these patients, most of these patients would not come to the clinical center if it were for this program because of the specialty issue, once again. And again, it's hard to get people who are in the academic environment to engage in a program like this with a lot of their time. And the reason being that in order to advance, you have to publish. In order to publish, you have to be an expert. How can you be an expert in undiagnosed diseases? That's basically, it's a dead-end job, I assure you. So failure is common, and the patients are very desperate. And I think I'd like to spend just 2 minutes reading these things, and then I have another slide, and then we're done. So just to go show how desperate patients are, I'll just read excerpts from a letter. Dear Dr. Gahl, I'm writing on behalf of my wife. Anne is devastated physically now and has lost the use of her remaining 3 fingers on her left hand. She's being treated regularly for depression and has frequent bouts of panic attacks, brought about by the fact that she is totally helpless in her Springfield room. She has suffered more than I believe is humanly tolerable, but astoundingly Anne is still here. It's almost as though she has died, and I get to talk to her from time to time. It is a daily battle, advocating and monitoring people to do what they're supposed to do and following up on what they said they would do but didn't. Anne can't fight for herself. She can't cry. She says everything with her eyes. I feel totally helpless to help her. Anne needs desperately to find the cause of her condition. And when we called back, she had died. A second letter here is, my name is so-and-so, I'm 26 years old, and this is my story. On June 26, 2006, my whole world changed. The night before, I had stayed with a friend and began vomiting blood. The next day, I continued to get worse, and even the slightest touch to my skin would cause excruciating pain. Over the next 9 days, I went to the emergency room 13 times, but I was only being treated for nausea and pain, and once I stopped vomiting, I was discharged. On July 4th, I went to the ER again, and they did a spinal tap and said my white blood cell count was very high. The week before Thanksgiving, I was again life-flighted to the hospital, but this time from such and such to such and such. And I was tested and was being treated and broadly diagnosed as having mixed connective tissue disease, etc. The hospitals now labeled me a hypochondriac, a frequent flyer, just some kind of slang for a pain druggie. So now, when I cannot stop and must seek help from the ER, they make me wait 7 to 12 hours to be seen by a doctor, even while I'm filling my bucket up, and where many times I'm also in severe pain while sitting in the waiting room in the wheelchair with dropping oxygen levels and blood pressure. They take their time. They've even gone so far one time to tell my mother, if we can't get her to stop, you'll have to take her to such and such because we're not admitting tonight. I can't say in words just how hurtful that makes me feel. So we called up her father, and she was also deceased. So then, here's a 46-year-old man who has spastic ataxia. And this came on late in his life, really a few years beforehand. And he shows pictures of himself, with his wife, and he worked out a lot, and he really wants a chance. So he wrote us with this letter from his daughter. And we saw him, and he has cerebellar and cerebral disease and peripheral neuropathy as well, and really is devastated, and he's going to die of this. And we're reasonably certain there's nothing we can do, and what he would like is for us to find this out to see if anything can be done for his daughter. So what we would like to do is to help the people to be stronger in the broken places, and occasionally we can. Thank you.